And welcome to the Social Determinants of Health legal series, where today we're going to focus on legal and healthcare. My name is Rodderick Sheppard, and I am a member, I'm a manager of prevention here at NASTAD, and my pronouns are he, him, his. All right, so welcome and introductions. This is the Social Determinants of Health team. I lead the project for the Social Determinants of Health and work in conjunction with my supervisor, Christina Santana, and also Maddie is a part of the team. We've been working on this for the past 2 months together, and this is actually my first webinar with NASTAD, so y'all be easy on me today. All right, so feel free to reach out to us if you have any questions or want any more information regarding the Social Determinant of Health programming at NASTAD, and we will definitely help you out. All right, so today's overview or the objectives for today, we'll have a brief overview of social determinants of health, review how legislation impacts healthcare access and quality, look at current examples of healthcare and legislation like Ryan White program, and then the Epidemic, EHE, Medicaid, Medicare, and Affordable Care Act, ACA. Identify successes and review current data for healthcare access and quality legislation, complete PrEP care access case studies and group discussions, time for questions, comments, and discussion. And also before I move forward, I don't know if our federal partners joined us for the webinar tonight, but we always like to thank them, in particular to our CDC project officer, Maria E. Alvarez. I don't know if she joined us tonight. Maria, you can feel free to take your computer off of mute if you want to say some words to my audience today. Maybe, okay, I don't think she's here. All right, well, let's get into it then. All right, so what is social determinants of health? So I thought it would be very important, as this being my first webinar with this series, to actually make sure that we're all on the same page in terms of like what is social determinants of health. So we're going to have a little brief overview about what social determinants of health is. All right, so the CDC defines social determinants of health, SDOH, as conditions in the places where people live, learn, work, and play that affect a wide range of health risks and outcomes. I'm going to play a brief video that goes into a little bit more detail about what social determinants of health is. Y'all make sure y'all let me know if the video is not playing or if there's any tech issues, and we'll try to fix it, all right? But I'm gonna see if it works for me.
At HHS, we define the social determinants of health as the conditions in the environments where people are born, live, learn, work, play, worship, and age. Social determinants affect our health, well-being, and contribute to health disparities and inequities as well. Healthy People, our nation's longest-running disease prevention and health promotion initiative, emphasizes addressing the social determinants of health to create environments that promote health and well-being for all. I'm Admiral Rachel Levine, Assistant Secretary for Health at the United States Department of Health and Human Services. Healthy People 2030 provides a framework for thinking about the social determinants of health across 5 domains. Here are the 5 social determinants of health. First, economic stability. People with steady employment are less likely to live in poverty and more likely to be healthy. By helping people earn steady incomes, we can achieve economic stability for all. Second, education, access, and quality. People with higher levels of education are more likely to be healthier and live longer. By helping students excel in school, we can improve educational access and quality. Third, healthcare access and quality. Many people in the United States are unable to get the healthcare services that they need. Increasing access to high quality, healthcare services will ensure more individuals can attain their full potential for health and well-being. Fourth, neighborhood and built environment. Health and safety risks, like high rates of violence and unsafe air or water, impact health and quality of life. By creating safe communities, we can provide opportunities to promote playing and physical activity. And fifth, social and community context. Increasing relationships and interactions with family, friends, neighbors, and community members is beneficial to an individual's health and well-being. To learn more and see how others are working to address the social determinants of health across the nation, please visit healthypeople.gov. Produced by the U.S. Department of Health and Human Services.
All right, and there's one piece in this video that they added in terms of the definition. I love that they added worship to the live, work, and play, I guess, definition of what social determinants of health are. I always like to look at health from a holistic perspective, where you're examining health from a physical standpoint, a mental standpoint, and also from your spiritual health. So I really love that they incorporated that into this video clip. All right, so let's move into factors of social determinants of health. So as you've seen in the video, Healthy People 2023 has a nice little visual graphic that kind of breaks down the social determinants of health. And today in particular, we're going to focus on the healthcare access and quality. So some factors of social determinants of health, again, is socioeconomic status, education, neighborhood and physical environment, employment, social support networks, and healthcare access. So legislation and healthcare access and quality. Some examples of legislation and healthcare include Ryan White, ending the epidemic, the EHE, Medicaid and Medicare, the Patient Protection and Affordable Care Act, the ACA, and the Inflation Reduction Act. So I'm going to go into each and every one of those pieces or those examples of legislation. And I wanted to start off with Ryan White, just to give a little history of it, because I don't recall in many of our trainings or webinars that we actually talk about who Ryan White is. So I thought it would be important to include this in the webinar. So Ryan White is a 13-year-old boy who was diagnosed with AIDS on December 17th, 1984, after receiving a blood transfusion. Unfortunately, he encountered HIV stigma and LGBTQ discrimination when returning to school in Indiana. People in this case assumed that because he had AIDS that he was a gay. Back then, when the virus was first known to us, it was also had the reputation of being a gay disease, which we know is not the case. He was given a prognosis of 6 months to live, but he actually lived 5 years later than expected and died in April of 1990. The Ryan White Comprehensive AIDS Resource Emergency Care Act was passed by Congress in August of 1990. So this is just tell you a little bit about the Ryan White program. Ryan White is a program for people who are low income living with HIV. And they get assistance through the program. Well, the assistance that they get through Ryan White includes medication, help with diagnosis, treatment, and prevention in response to the EHE, medical care, and as well as essential support service for retention and care. Ryan White funds and provides grants to cities, states, counties, and community-based groups that help with providing medical care, medication, and essential support services to people living with HIV, any health-related HIV health outcomes, and reduces the HIV transmission rate. More than 50% of people diagnosed with HIV receive services through Ryan White. Ending the HIV epidemic in the U.S. initiative, EHE. So the United States Department of Health and Human Services, HHS launched the Ending the HIV Epidemic EHE initiative in 2019. CDC collaborates with national prevention partners to maximize the impact and the effectiveness of treatment as prevention, or as some of us may know it as TASP. In conjunction with the CDC, state and local governments, people with and at risk for HIV, and federal partners work together to expand the highest impact HIV prevention strategy: diagnose, treat, prevent, and respond. And then finally, along with providing priority areas with additional resources, technology, and expertise, they are working to address racial, ethnic, and geographic disparities gaps that happens within HIV. This is a shameless plug. This is a resource that we released last month at NASTAD. So I wanted to plug this to have a little more promotion for it. And then also, this also functions as a resource. So we interviewed some of the phase 1 jurisdictions to find out, how are they engaging with new and non-traditional partners, providing community support, and talk about their program successes. We designed this tool to help public health professionals learn from each other's program successes, strengths, and opportunities. At the end of the webinar, you will have access to the slides and this information. So I've included a hyperlink to that document. Again, should you have any questions about this document or anything related to the Social Determinant of Health series, please feel free to reach out to me. And again, you'll have access to the slides, and my contact information is in there. All right, so let's talk about Medicaid. So the Center for Medicaid and Children's Health Insurance Program, CHIP, oversees all national program policies and operations related to 3 programs: Medicaid, Children's Health Insurance Program, CHIP, and Basic Health Program. So Medicaid was signed into law in 1965. All states, including DC and US territories, have Medicaid programs to provide health insurance to people with low income. Children Health Insurance Program, that was signed into law in 1997. It provides coverage to children with families who don't qualify for Medicaid but can't afford private insurance. So this is an example where legislation is trying to capture people who are falling in between the cracks and the gaps of services. And another example would be the Basic Health Program, which came through from the ACA. Hope it's not too loud. I have a lot of motorcycles outside of my apartment complex. But yes, the Basic Health Program started through the ACA, and it gives states the options to create a basic health plan for those who do not qualify for Medicaid or CHIP or have income between 133% and 200% of the federal poverty line. All right. Now, there's a difference between Medicaid and Medicare. So Medicare is health insurance for people who are 65 and older, people with disabilities or end-stage renal disease or ASL. Or ALS, I'm sorry. The federal partners that oversee Medicare program is the Center for Medicare and Medicaid Services, CMS. CMS is a branch of the Department of Health and Human Services. All right, and this is another video clip. This explains the parts of Medicaid, and I'm certain this video can explain the parts of Medicaid better than I can, and I really like it. Thought this was really helpful too. So I'm gonna go and play that. It's another short one.
When you're first getting started with Medicare, there can be a lot to learn and consider, and it might seem overwhelming. Let's start at the beginning with the ABCs and D of Medicare. Medicare includes parts that are the building blocks of your health and drug coverage: Part A, Part B, and Part D. And there's also Medicare Advantage, sometimes known as Medicare Part C. Let's start with Medicare Part A. Medicare Part A is sometimes called hospital insurance. It covers hospital care, like inpatient care at a hospital, skilled nursing facility care, hospice care, and some home health care. Usually, you don't need to pay a monthly premium for Part A. Medicare Part B, or medical insurance, covers services like certain doctor visits, outpatient care, medical equipment like wheelchairs, and preventive services like flu shots. With Part B, you'll pay a premium every month. In many cases, if you don't sign up when you're first eligible, you'll have to pay a late enrollment penalty, which is added to the monthly premium cost for as long as you have Part B. That can add up, so it's important to pay attention to your deadlines. Medicare Part A and Part B are both under what's called Original Medicare. If you want drug coverage too, then you can join a separate Medicare Part D plan. Medicare Part D coverage is provided by private companies that you can choose from. For a Medicare Part D plan, you'll pay a monthly premium that depends on the plan. Remember to consider your plan options when you're first eligible to avoid late enrollment penalties. And finally, there's Medicare Advantage, also known as Medicare Part C. Medicare Advantage plans are another way to get your Medicare Part A and Part B coverage. These are Medicare-approved plans offered by private companies that bundle your Part A and Part B coverage, and usually include Part D drug coverage too. Most plans include extra benefits like vision, hearing, dental, and more. Ready to learn more? Visit Medicare.gov or review the Medicare and You handbook. You can also watch the other Get Started with Medicare videos at Medicare.gov. This product was produced at U.S. taxpayer expense.
All righty. All right, so now we're going to talk about the Patient Protection and Affordable Care Act, the ACA. The Patient Protection and Affordable Care Act, the ACA, was enacted under the Obama administration on March 23rd, 2010. It was previously referred to as Obamacare or PPACA. I'm happy we just changed it to ACA because that was a mouthful. All right, so primary goals are to achieve affordable health insurance, expand Medicaid programs, and the tidbit that I wanted to definitely add into the slides was that not all states have expanded their Medicaid program. This was an optional expansion. It wasn't a mandated one. And then finally, to support innovative medical care delivery methods to lower healthcare costs. And this is some recent piece of legislation that President Joe Biden just signed into effect, the Inflation Reduction Act. So what this does is it expands Medicare benefits, which will include free vaccinations. They were able to reduce insulin down to $35 monthly, which is huge. Caps out-of-pocket costs, so for $4,000 or less and up until 2024, and then settling at $2,000. I believe that's in 2025. I'll have to update that. Also, it allows Medicaid to negotiate, requires pharmaceutical companies to rebate back prices increases higher than inflation, and it also lowers healthcare costs. So the average enrollee on a marketplace saves $800 a year now. All right, so how does legislation impact healthcare access and quality? So based upon just a few of the legislation acts that we just reviewed, this is some information where we can understand how legislation impacts healthcare. So it provides access to high quality medical care, provides drug coverage, increased access to healthcare and affordable insurance for adults and children. It creates programs to help address social determinants of health for better health outcomes, identify strategies to address the gaps and barriers in healthcare for equality. Reduce out-of-pocket expenses for patients, provides protections for both medical professionals and patients, access to services that include diagnosis, treatment, and prevention for disease control. And then also provides regulation for healthcare professionals, drug companies, and insurance providers. Here's some current data on healthcare legislation. So in terms of Ryan White in 2020, they reported servicing more than 561,000 people. 89.4% of Ryan White recipients in HIV care reached the viral suppression. Which segues into some other data. The CDC reported on 3 recent studies, Partner, Opposites Attract, and Partner 2, that all showed no new HIV infection for mixed status couples who engage in condomless sex and their partner was virally suppressed. And then HHS released a report in 2021 that showed a record number of 31 million Americans have health coverage through the ACA and a reduction in the uninsured rate in every state. So that is pretty major. All right, so I've been talking for the past 20 something minutes. So now it's an opportunity for us to kind of engage. I do have some prep healthcare access studies, and just to give you a little bit of background about my work. So in my previous role, I was a prep specialist at Women Walker Health in DC. And a lot of these, or the 2 case studies I've included in this presentation are actually situations that I have encountered in that role. So we're gonna go and check them out and see what it's given. All right, y'all, so meet my good friend, Miguel. Miguel is a 34-year-old cisgender bisexual Latin man who started the process of getting on PrEP. However, he has not started his medication because he has a copay he cannot afford. Also, he calls to inform his provider that he received a $300 lab bill. He reported he cannot afford to pay that amount every 3 months for labs. So let's talk about Miguel for a minute. In the comments section, if y'all want to sound off to some of these questions or put in what you think might be the best solution for our friend Miguel. Here's some questions to consider as we think about solutions. Who would be the best person to help address the patient's concerns about the lab fee? What options does the patient have to cover the copay of the medication? What internal programs are available that can help alleviate PrEP access barriers? Well, then, can I see the chat somehow? That's good. And this is the case scenario for y'all to take a minute to look over, put some of the comments or your thoughts in the comment section about how we can best help Miguel. All right. So we're going to move on to the solution because I do want to make sure we have some time for some general discussion. So in terms of solution for patient care navigation, in these situations, what we normally did was we would contact the billing department to see if the billing codes are correct or can be adjusted to eliminate lab fees. There were quite a few patients who when we referred them to our billing specialist, that they just needed to change the codes and everything was fine. They didn't have to worry about paying any astronomical amount for fees for their lab work. Identify a patient qualifies for any drug copay assistance programs. Contact insurance providers to advocate that patients should not have cost-sharing expenses due to the requirement that all qualified health plans cover PrEP. This is an initiative that came as a result of PrEP getting a grade A from the U.S. Prevention Task Force, I believe. And this has been like a really big topic because a lot of insurance companies are still, like a lot of patients are still having cost sharing expenses, and we have to hold our insurance companies accountable because they should not have any cost sharing expenses. Identify if sliding fee scale or self-pay for lab work is a more affordable option. So in this case, for example, at Women Walker Health, they had They had a set rate for their labs, and oftentimes the set rate for their prep labs was way cheaper than the insurance companies. I've had patients who said that like their lab fees were at least about over $300, and Women Walker's fees were only $59 for your quarterly prep labs. All right. Me and my girl Tammy. So Tammy is a 30-year-old African-American woman on prep. She reported she will be transitioning to a new employer soon, but her new health insurance plan won't be effective until after her 90-day probationary period. She wants to remain on PrEP while waiting for her new insurance coverage to be effective. She reported that her partner is HIV positive and they engage in condomless sex. So again, sound off in the comment section what you think about Tammy's situation. How can we best help Tammy and her transition to a new employer where her insurance does not start until after her probationary period is over? Here's some questions to consider as you're thinking about solutions. What stands out to you about Tammy's situation? How can you stop Tammy from having a gap in her PrEP adherence? So I'll give you a couple of seconds to chew on this for a little bit and sound off in the chat what you think or how you think we can best help Tammy. So we got patient can use a GoodRx coupon to lower drug costs, connect Tammy with a patient assistance program. Okay, through the PrEP pharmaceutical company. Would be great if. I love that. Okay, so a 90-day supply of medication to be covered outside. Yeah, outside the PrEP access programs. Yes, love all of that. Finally got access to the chat, y'all. It's a learning experience, right? All right, so on to how we address the situation. So shout out to whoever said that it would be nice to receive a 90-day prescription. My go-to solution for scenarios like this, and I've even used this in my personal healthcare when I was transitioning employers and needing my medication, is getting a 90-day prescription to hold me over until like the transition is, settled and done. So what we would do with our PrEP patients is we would go ahead and, have them do a 90-day or have them do their quarterly PrEP labs, regardless of where they are in the process. So that clears them for the next 90 days of having medications, and the medical provider, so the patient won't have to worry about doing any labs while she's out of, while she doesn't have health insurance coverage. So after the labs are completed, if the patient has an insurance plan where they can receive 90 days all at once, then no other, action is required. However, in the event that the patient is can only get 30 days at a time, they're going to have to do some creative solutions to get through this situation. So again, in the past, I've done this before where I was transitioning employers and transitioning insurance, and I needed my medication. And the pharmacist suggested was like, well, I can't give you 90 days all at once because of how your insurance is set up. But if you tell me you're going on vacation, I can get you all of your medication. So the vacation override is one of my favorite steps to kind of help patients, get all of their medication all at once in situations they really are going on vacations, or even situations like this with Tammy. So the person who said that, yes, that is the perfect case scenario for Tammy. And then we go into identifying if they qualify for any drug assistance program. And as a last result, identify if patient can afford to pay covert insurance and maintain health insurance throughout the employment transition. All right, so included in the slides, I wanted to make sure I include some information about some of the topics that we touched on today. In particular, I want to highlight the last one on this particular page. If you want to know a little bit more information about public health and legislation, the CDC actually has a training resource for public health, and that's called Public Health Law Academy. So definitely check that out if you want to know some more information about healthcare and legislation. And then I've also incorporated some NASTAD resources in the slide as well, based on some of the topics we covered. And we were talking about billing and coding, and so I have some stuff on there as well. And I also have included the community development highlights as well. So again, at the end of this webinar, everyone will have access to the slides and some of the resources that I posted. And this is my reference pages. And now the legendary Destiny's Child independent video question. It's time for questions, comments, let's chit chat. Any thoughts, any feedback, feel free to unmute your mic, or if you want to use the chat box to ask your questions, and you can do so. Any questions, any comments? Any discussion that anyone in the audience wants to chime in on, that the time is now. Yes, of course, no problem. Thank you for being here with us today. A great presentation. Thank you for all this knowledge. Oh, thank you, everyone. I really appreciate this. I hope everyone enjoyed the webinar. Anybody want to unmute their mic and say anything?
How do you motivate people to get enrolled into PrEP care when they otherwise wouldn't enroll in it? One of the things that I hear from young people is they're afraid of their parents' insurance revealing that they're on PrEP or that they are gay.
Oh, okay. That scenario has come up quite frequently in my experience. For me, my first go-to for that is definitely education. Making sure that your clients know the facts about, the care and getting on PrEP and what that looks like. And then in terms of the whole piece, I'm trying to think of ways we actually used to have to handle the situation with the parents being able to see, what happens, when they go to the doctor's office. I know one way is to encourage them to kind of be open and honest with their parents about what they need for their healthcare, but I can understand in the queer community that could be a dangerous thing for some. So if that's not a feasible option or a step they're not ready for, then we completely understand that. I know we do have some more resources on situations dealing with like health, adolescent, youth, and insurance. Before I send the slides out, I'll make sure to add that under the NASTAD resources, and that's something you can check out for the other part of that question, because I cannot recall how we used to handle those situations. And I think it's a situation where I believe a lot of people, like with your insurance company, like your parents will have access to like what your visit is, but it doesn't happen as easy as that. Like, I think they would have to either like send them something in the mail about the care. So maybe there might be like a bill, or either they might have to actually inquire about it. I'm not quite certain of the second piece, but in terms of like encouraging people to get on PrEP, I think education is key, starting with facts, review the data. I'm a big advocate for PrEP and educating members of my community because working in the PrEP clinic, I think I was there for almost 3 years, and I can count on how many patients we had zero PrEP clinic. Like it's this definitely backs up PrEP, and then also U equals U. So. Thank you for your question.
Thank you. That'll actually help a lot, I think.
Any other questions, comments? No one wants to chit chat with me. Well, all righty.
I got a question, Rodderick.
Okay.
Yeah, just one. It's a little bit more of a broader question. So like I've probably not like a simple, like easy answer, but just like I know sometimes it's easy to like we need to change the legislation. We need to change the law. We need to make this happen. And it can get really easy to get, just kind of like the lift is so big. It's so heavy to like to try to change that. Like, changing HIV criminalization laws in your state, like how much work goes into modernizing them, but still recognizing it's not far enough. And just wondering if you could speak to like kind of like the process of like building that power towards changing like policies or doing that, or kind of like how can you stay engaged in that process without getting kind of like disengaged throughout it and like kind of like, oh, it's too big, like I give up, like I can't adjust this system, because I know it can just get really frustrating, like, oh, if we could just buy PrEP directly with this funding source, we could like create this whole program, but we can't. And not just getting stuck in that, but like, kind of that both and like, how do we still kind of work around that while trying to get that bigger picture change happening?
Okay. Well, the first thing I would encourage is I would say it would be good to align with people who have the same interest in impacting healthcare legislation issues, so you won't feel like it's just you in a battle. That's the first thing. So definitely there's room for collaboration in this process. And I imagine like when you work with a team of people, it would help alleviate some of those feelings of like, this is too big for me to handle, or I don't know if it's realistic. I think we have shown like, we actually are making strides towards healthcare reform and what that looks like. So I think it's definitely possible for us to be able to identify the gaps in our healthcare system and how we can change legislation through that way.
Thank you. I appreciate that.
And another piece I want to add to that as well is I think it's important to stay informed about what's happening with healthcare and legislation. Even during this presentation, like it was like a mental note for me because the whole the Inflation Reduction Act, I didn't know that was a thing until like, I sat down and started doing my research and I was like, oh, this happened not too long ago and I didn't even know this. So there's also an importance of definitely staying informed about what's happening with healthcare and legislation because it could have positive impacts and it can also have some negative impacts as we see with Roe versus Wade and even with the Texas judge and the PrEP in Texas, like, yeah. It can have negative impacts. I wanted to kind of go into maybe some more of the opportunities in healthcare, but I wasn't certain if I was going to have enough time. So I was like, maybe this will come up in the discussion, but that's definitely a challenge and an opportunity. Any other questions, comments? Feel free to unmute your mic and join the discussion. If anyone wants to respond to any questions that were previously asked, you can too. You're welcome to do that. Okay, so the thing with HIV criminalization, Elizabeth, is we're hosting a webinar next month on HIV criminalization. So I don't know if you want to wait to join that session. We'll have a lot more information about HIV criminalization next month, and I'll go to the slide that shows the dates for this series. I plan on doing this series all the way up into the beginning of next year because in the slides, I wanted to also talk about youth and healthcare and legislation, but as I started to put slides together, like I definitely felt that we can do a whole topic on youth and adolescents in terms of healthcare and social determinants of health and legislation. So yeah. All right, so if no one else has any other comments, I don't want to hold you up too much longer. I guess me out time back. So again, so the upcoming information on the Social Determinants of Health legal series. So as I just said, the HIV and STI criminalization webinar will be hosted on October 26th at 3 p.m. Then we also have a housing webinar on November the 15th at 2:00 p.m. And then we take a break because a lot of people travel during the holiday season, or like I like to call it, the seasons of best eatings, where you get a lot of good food and you need time off from work to recover. We're going to take a break, but then we're going to jump into the new year's to complete the series with the youth and adolescents and the legal series. All right. Well, thank you so much for being here with us today. Again, we will be sending out recordings of this webinar, and then also you'll have access to all the resources and the slides that we use today in today's presentation. Again, feel free to contact us as NASTAD, myself, Christina, or Maddie if you have any questions about the Social Determinants of Health legal series or the general programming. We will happily help you out and assist you.
Thank you, Rodderick. Have a good day, everyone.